Our next speaker is Dr. John Looney. John is Professor of Medicine and Environmental Medicine, University of Rochester. Received his bachelor's degree at Harvard, his medical degree at University of Rochester. Then he was a resident at Strong Memorial. He was a fellow in allergy and immunology at University of Rochester, and then a postdoc fellow in immunology and also in infectious disease. He has numerous peer-reviewed publications, reviews, book chapters, and this morning he's going to give us a talk on new treatments for SLE.
I'm delighted to be here, I guess I forgot that we're actually on Central Time here, so I was thinking that we were quite far behind schedule, but I'm happy to say that I figured this out now. This is a very interesting time to be talking about new treatments for lupus, obviously, since for the first time in 50 years we have a new treatment for lupus that's actually FDA approved. Just in terms of disclosures, these are sort of the companies I've worked with in the last year. Genentech, of course, is involved with rituximab. The others are not really, I guess Bristol Myers Squibb has done some work with lupus, and I'll mention that briefly. But there's no major conflict, I don't think, with this talk. What's new in the treatment of lupus? I mean, the big thing, of course, is biologics, and there's been a lot of activity with that, and I'm going to spend most of the talk on the biologics. But there's also some new information about established treatments, and I think it's important to at least make sure everybody is aware that we are continuing to learn more about the drugs that we're already using. And there are some new drugs that are just beginning. They're sort of in the concept phase, and I'm just going to mention one of those, which I think may be particularly interesting, and it sort of represents a class of new agents. I'm very lucky that Xavier went before me, and I'm also very unlucky. I mean, the good luck is that he gave a beautiful talk about the pathophysiology of Sjogren's syndrome, and that sort of is very similar to the pathophysiology of lupus. The bad news is that he did such a good job, I'm sure that this is going to seem very old hat to most people now. There's really, at least when I think about these systemic autoimmune diseases, I really think about them in different phases. And there is this phase of asymptomatic autoimmunity, and how that comes about is also certainly very interesting. And this is really what you're talking about. You're talking about using the antigen-presenting cells, activating T cells, and getting really T-dependent production of antibodies, and they are eventually produced in plasma cells. And the antibodies that are produced, of course, are not random, as you heard in the earlier talk. They are directed against autoantigens where you can get a second signal. In order to really make an immune response and not be tolerant, you have to get a first signal, which is recognition of the antigen by T or B cells. But you also have a second signal that says, yes, go ahead, this is not self, go ahead and make an immune response. And because the autoantigens that are involved in systemic autoimmune diseases such as lupus and Sjogren's and scleroderma and dermatomyositis interact with these toll-like receptors, they get a second signal. And that's why we're making them, presumably. When you do knock out mice, if you knock out the appropriate toll-like receptor, you get rid of the antibody production against those antigens. And it's also important to remember that there are a number of different cells that are important for this interaction with toll-like receptors, one of which is the B cell. So there's a lot of emphasis on gamma interferon production with toll-like receptors, but it's also important to remember that the B cell also has toll-like receptors. They don't make so much alpha interferon, but they, of course, get activated to make their autoantigens. So the next phase is the effector phase of autoimmunity. And this is where the antibodies produced by the plasma cells, which can be short-lived or long-lived, come into play. They can either interact directly with their targets in causing cytopenia, antiphospholipid antibody syndrome, neurotoxicity, congenital heart block, etc. Or they can form immune complexes, and then with these immune complexes can stimulate plasmacytoid dendritic cells to make their alpha interferon. They can also interact with macrophages and neutrophils and platelets and other cells that have Fc and complement receptors to produce a whole bunch of inflammatory components. The autoantigens, we already mentioned, can interact with sort of the different players in cell-mediated immunity to give you a inflammatory response or to produce autoantibodies. What's interesting is that, probably all you need to keep things going may be to have these long-lived plasma cells, release of autoantigens, and then all of this can continue to go. And this is one of the reasons I think these autoimmune diseases are so tough, is that these plasma cells can produce these autoantibodies for decades, and they're very difficult to hit. So there's sort of a real intransigent component to these autoimmune diseases that make autoantibodies that are pathogenic. There's also a triggering component. A lot of our patients have these autoantibodies for years. A lot of them are sequestered antigens, and things like nuclear antigens or cytoplasmic antigens that are not expressed on the surface of cells. They're invisible, so you don't really get the immune complexes. You really don't get the disease. Or you have antigens that are in the central nervous system, and because of the blood-brain barrier, anti-neuronal antibodies don't get in there to cause seizures or neuronal death or et cetera. But then, as was mentioned before in the first talk, you can get damage by UV light, keratinocytes releasing antigens, and now you can begin to form these immune complexes. Viral infections and adverse reactions to drugs also can release antigens, particularly in lupus patients. Things like sulfa drugs, where you have an increased risk of adverse effects, are notorious for triggering flares of lupus, but also viral infections can do it. And then you also have just the activation of the immune system can release autoantigens. Something that's been relatively recently discovered is that neutrophils can send out these nets, which are DNA and protein coated, DNA coated with proteins, which are used to help trap microorganisms, but they're also extremely good at initiating inflammatory responses when you have these autoantibodies like you do in lupus and Sjogren's. So what's new in the treatment of lupus? Well, as you can see here, the major new thing is that belimumab, phase 3 trials have been completed, and belimumab is now approved drug for lupus. Just out of interest, are there many people who have already prescribed belimumab for their patients? I see maybe 4 or 5 hands. I was talking to the people from the company. There's maybe 1,000 prescriptions that have been written nationwide so far, but that's probably just the beginning of a wave of treatments. So this belimumab is certainly the biggest news in the new treatments of lupus, and we're going to spend a lot of time going over that. As mentioned before by Xavier, there are 2 really growth factors for B cells that are important, and atacicept with the soluble TACI receptor hits both of those, and as you might expect, has a pretty profound effect on B cell physiology. Rituximab is certainly has been out there for a few years now. There is some new information about the longer-term follow-up of some of the patients, especially in the Looney trial. Epertuzumab is in phase 3 trials. There was a phase 2 trial, TRuE-A trial, which is a bit promising. Atacicept is out there. It's still in clinical trials. The antibodies against alpha interferon are in clinical trials. And there are some antibodies against inflammatory targets like tocilizumab and anti-TNF that have been tried in lupus, and we'll mention those briefly. This is sort of looking at all the B cell targets A lot of them have come and gone. The anti-CD40 ligand was used for a period of time and found to have unacceptable side effects. People got vascular lesions.